Welcome to this deep dive into free flap breast reconstruction, where we break down flap selection, harvest techniques, and salvage protocols for the real world. You are making critical decisions in the operating room every single day, and we are here to unpack the raw clinical realities behind those decisions.
Yeah, and you already know the abdomen is the undisputed heavy hitter for autologous reconstruction, but getting the right tissue to the chest without wrecking the donor site takes serious precision.
Exactly. Let's look at patient selection first and that fundamental volume algorithm. When you are evaluating a patient with a volume requirement under 750 cc and they have mild to moderate excess abdominal fat, you're usually pointing straight to a DIEP flap.
Right, it makes sense. But if that volume requirement jumps over 1,000 cc or the patient simply has an abundance of abdominal fat, a free TRAM often becomes the preferred play.
You cannot just look at the raw volume, though. You have to factor in the skin envelope, existing scars, and the incredibly difficult task of trying to match a contralateral ptosis in a unilateral reconstruction.
That volume algorithm is a great baseline, but let's talk about the surgeon-to-surgeon reality once you are actually in the OR. There is a massive reliance on perforators right now.
Oh, for sure.
A lot of surgeons operate under the assumption that every single patient has a dominant abdominal wall perforator just waiting to be found. They treat the DIEP flap like it can be performed on absolutely anyone. In real life, that simply is not true.
Right, a dominant perforator is not always there.
Exactly. Sometimes a musculocutaneous flap is not just an alternative option, it is an absolute necessity to ensure flap survival. That brings up the muscle-sparing classification system.
Which we all know the textbook definitions for. We break the rectus abdominis into medial, lateral, and central longitudinal segments.
Right. An MS0 preserves no muscle, you take the full width. An MS1 preserves either the medial or the lateral segment. An MS2 preserves both the medial and lateral segments, taking just the central strip. And an MS3 preserves all three segments, which is effectively your standard DIEP flap.
But wait, aren't we trained to spare the muscle at almost all costs to prevent donor site morbidity? I mean, why would we actively choose to downgrade to an MS2 if we are already in there looking for a DIB?
Because sparing the muscle does not matter if the flap dies on postoperative day 2. Here's the key point. If you are doing your intramuscular dissection and those perforators are sitting under 1.5 millimeters in diameter, pride has to step aside.
You cannot force it.
No, you do not force a DIE just to say you did one. Converting to an MS2 free TRAM is a smart clinical audible. You take that small central segment of muscle specifically to capture multiple smaller perforators.
Doing that prevents massive fat necrosis and venous congestion down the line. It is about prioritizing blood supply over anatomical ideals.
Absolutely. You cannot just cross your fingers and hope you find a good perforator once you make the incision.
Yeah, that reliance on hope is what makes preoperative imaging so critical today. We really have to contrast the old school methods with current protocols. Think about the handheld Doppler ultrasound.
Oh man, we have all been there.
Right. Pressing that probe into the skin, listening for the arterial swoosh, and thinking we mapped out the perfect flap territory. But it had massive limitations.
It gave you zero three-dimensional architectural detail, and the false positive rate was staggering.
We are talking about a 46% false positive rate for localizing perforators. That is basically a coin toss.
It really is. You could open the patient up and find a useless muscular branch instead of a dominant perforator. Today, computerized tomographic angiography CTA is the current workhorse for a very good reason.
It completely changes the preoperative game.
CTA is the gold standard because it actually maps the deep inferior epigastric artery branching pattern in 3 dimensions. You get axial and coronal multi-slice images showing the exact course of the perforator straight through the muscle.
So you can compare the right and left sides before the patient is even draped.
Exactly. And more importantly, it helps you avoid the lateral row perforators whenever possible. Going after lateral row perforators significantly increases your risk of intercostal nerve injury during the harvest. If you can identify a solid medial row perforator on the CTA, you take it.
The CTA also gives you a massive advantage when dealing with abdominal scars, right? We know that paramedian incisions destroy DIEA perforators the most.
On the flip side, laparoscopic ports do the least amount of damage. They usually just push the vessels aside. You can actually see that exact vascular integrity on the scan and plan your harvest accordingly.
But what about patients who need to avoid radiation entirely? That is where magnetic resonance angiography, MRA, steps in as the next generation of mapping.
Yeah, it has slightly lower spatial resolution than a CTA, but the contrast resolution is significantly higher.
And that high contrast resolution is incredible for spotting tiny perforators that a CTA might actually miss in a dense abdominal wall. You use a gadolinium-based contrast agent, and the data shows you can find the intraoperative location of each perforator within 1 centimeter of where the MRA predicted it would be.
It will even tell you if the superficial inferior epigastric system is dominant. That effectively makes the decision to switch to an SEA flap for you before you even scrub in.
Finding the donor vessel is only half the battle, though. You have all this meticulous preoperative mapping, but it means absolutely nothing if the plumbing on the chest wall cannot support the tissue.
Integral to flap survival is selecting the right recipient vessels. The debate usually comes down to the internal mammary artery system versus the thoracodorsal system.
And in almost every clinical scenario, the internal mammary artery, the IMA, is the vessel of choice for most delayed and immediate reconstructions.
The fluid dynamics back this up completely. Let's look at the hard numbers. The blood flow rate of the IMA ranges from 15 to 35 milliliters per minute. The average sits right at 25 milliliters per minute.
Right.
Now, contrast that against the thoracodorsal artery. Its flow rate is a measly 2 to 8 milliliters per minute, averaging just 5 milliliters per minute.
Looking at those numbers, it is a massive difference in perfusion volume. When you are relying on that flow to keep a large volume of transferred abdominal fat alive, you obviously want the IMA.
The artery diameter at the fourth rib is typically 0.99 to 2.55 millimeters, and the vein is 0.64 to 4.45 millimeters. In the OR, you usually expose the IMA at the third or fourth interspace.
Right, you excise the cartilaginous segment of the rib, carefully incise the perichondrium, and isolate the vessels. You are almost always doing this under loop magnification. So if the IMA is that vastly superior, why would anyone ever use the thoracodorsal system?
You usually only use the thoracodorsal system if a modified radical mastectomy has already exposed it. If the general surgeon has already done the heavy lifting and the vessels are sitting right there, pristine and ready, you might use them for a smaller flap.
Otherwise, with the prevalence of sentinel lymph node dissections today, the axilla is generally left completely alone. Dissecting into a virgin axilla just to access a lower flow vessel makes no sense.
Exactly. The IMA is the most logical, accessible, and robust target.
So you have your recipient vessels prepped and ready on the chest. Let's dive deep into the abdominal harvest nuances. The DIEP flap makes up about 70% of all abdominal free flaps.
You make your standard transverse incisions, marking out the anterior superior iliac spine. You elevate the flap from lateral to medial. Once you visualize that network of perforators, you outline the anterior rectus sheath to encompass them.
You need a single perforating artery and vein of at least 1.5 millimeters to make this work.
And the harvest is tedious. As you dissect the perforator through the rectus abdominis, you have to meticulously unroof the vessel and clip the tiny muscular branches. Here's a major clinical pearl. You absolutely must preserve the lateral intercostal motor nerves.
They pierce the muscle right at the junction of the lateral and central longitudinal segments.
Right, and if you get impatient and cut them to free up your pedicle, you denervate the muscle. You get an iatrogenic abdominal bulge. It is that simple. You have to carefully follow the vessel through the muscle, moving from the lateral edge toward the iliac vessels.
You do not stop the dissection until the pedicle diameter hits 2.5 to 3 millimeters. You need that caliber to match the IMA.
That intramuscular dissection takes serious time and finesse.
But what if you could skip the fascial and muscle cuts entirely? That brings up the SIEA flap based on the superficial inferior epigastric artery. The appeal here is massive. No fasciotomy, no myotomy.
You are just taking an adipocutaneous flap perfused by a direct superficial perforator that never courses through the rectus muscle at all.
Whoa.
The vessels cross the inguinal ligament about 1/3 of the distance from the pubic bone to the ACES.
But there is a huge catch. This flap is only viable in about 30% of women. The vessels are often entirely absent, or they're just too small to support the tissue volume.
You need the SIA to be at least 1.5 millimeters as it enters the lateral edge of the flap. If it is smaller than that, your failure rate skyrockets and you are heading back to the OR.
And even when you do find the right caliber vessel, there's a mechanical issue you have to manage during the inset.
Common pitfall right here. With the SIA flap, the pedicle enters at the extreme edge of the flap, not the undersurface like a central DIEP perforator. If you try to do a standard inset on the chest wall, folding the flap under, you create a sharp 180-degree kink in the pedicle.
It acts exactly like a kinked garden hose. It shuts off your arterial flow immediately.
You have to use the Zen technique to prevent this mechanical failure. You de-epithelialize the inferior 2 to 3 centimeters of the flap edge. Then you release the rigid dermis at the new epidermal edge. Finally, you orient the pedicle inframedially against the chest wall.
That maneuver creates a smooth, gradual curve for the vessels instead of a hard fold, completely protecting your flow.
It is a brilliant salvage maneuver for the inset geometry. But what happens when you look at a patient and the abdomen is completely off limits?
All right, let's say they have extensive scarring. Maybe they had previous lower abdominal transverse incisions that completely divided those superficial vessels. Or maybe they simply lack the fat volume for a breast mound. We have to move to Plan B.
That means looking at the gluteal flaps, specifically the SGA and IGA, and the medial thigh flaps like the TUG or TMG.
Let's break down the superior gluteal artery perforator flap, the SGAP. These flaps provide incredibly durable tissue. Fat necrosis is actually quite rare because the subdermal plexus in the gluteal region is so robustly developed from the constant pressure of sitting.
But the harvest is notoriously difficult. Contrast the SGA with the DIEP. In a DIEP flap, you actively look for a central perforator to get equidistant perfusion across the entire skin paddle. But in an SGE, you actually prefer a peripheral or lateral perforator.
Why? Because medially based gluteal perforators only yield about 4 to 6 centimeters of pedicle length.
That is incredibly tight for reaching the IMA on the chest. Lateral perforators give you 6 to 8 centimeters of length, which is absolutely crucial for attention-free anastomosis. Also, the dissection plane is completely different.
Right, a DIEP dissection runs relatively parallel to the skin as you skim over the fascia. An SGAP dissection runs perpendicular.
You are going deep subfascial, digging straight down through the thick gluteus maximus and medius muscles. You have to navigate a massive network of venous branches before you even hit the deep fibrous fascia. It requires a completely different surgical mindset.
You also have the IGAP, the inferior gluteal artery perforator flap. Use the exact same gluteal landmarks, the greater trochanter, the posterior superior iliac crest, and the coccygus. The incision sits right in the gluteal crease, which hides the scar beautifully.
But the dissection carries a major risk. You have to watch out for sciatic nerve exposure. Irritating that nerve causes severe postoperative pain, and the patient will be stuck with strict sitting restrictions for days, which makes recovery miserable.
If the buttocks are not an option at all, you look at the transverse upper gracilis, or T-yoke flap. This is great for patients with flat abdomens who only need a smaller volume reconstruction, ideally in the 150 to 550 cc range.
The preoperative marking for the TUG is critical. You evaluate the patient standing up, not lying down. You pinch the medial thigh tissue to gauge a safe flap height, usually aiming for 8 to 10 centimeters so you can still close the donor site primarily.
During the harvest, you take the skin paddle, the superficial nerves, the gracilis muscle itself, and usually the saphenous vein to provide extravenous drainage if the primary vena comitantes looks sluggish.
So you transfer the tissue to the chest, you complete the microvascular anastomosis under the microscope, and the flap pinks up. The surgical high kicks in.
But then you enter the most critical phase of the entire operation, the salvage window. We have moved way past the traditional methods of just checking flap color, feeling for tissue turgor, and timing capillary refill with a Q-tip.
Today, intraoperative monitoring relies heavily on fluorescent angiography, using indocyanine green, or ICG. You inject the ICG intravenously, and a specialized laser captures real-time perfusion images on a monitor just 15 seconds later.
ICG has completely redefined our understanding of clinical perfusion zones. For decades, we relied on HeartRamp's classic perfusion zones for abdominal flaps. We assumed perfusion followed a strict medial to lateral degradation.
But ICG proves that anatomical dogma is not always accurate in real life. For example, the imaging frequently shows that the distal lateral segment adjacent to zone 1 actually outperfuses the medial zone sitting on the exact opposite side of the midline.
You can literally watch the screen and see dark areas of relative hypoperfusion at the edges of your flap.
It allows you to confidently resect that compromised tissue right there in the OR, tissue that would otherwise inevitably turn into hard fat necrosis or a necrotic Escher weeks later. It takes the guesswork out of the trimming process.
But the monitoring obviously does not stop when you close the skin and send the patient to the ICU. You have to know your hard ischemia thresholds during that postoperative salvage window. The clock is always ticking.
For muscle-based flaps, like your free TRAM or your TUG flap, irreversible muscle damage occurs after just 2 hours of ischemia. You have a very short runway to recognize a problem and get back to the OR.
For perforator flaps like the DEP or SAE, where no muscle is included in the harvest, that salvage window expands to roughly 3 to 6 hours before the fat undergoes irreversible necrosis.
Recognizing the failure early is everything. You have to be able to instantly differentiate the clinical presentation of failure at the bedside. If you are dealing with inflow issues, meaning arterial thrombosis or spasm, the flap turns stark white or pale.
It gets physically cool to the touch. Capillary refill is severely delayed or absent, and when you put the pencil Doppler on the skin island, you lose your short biphasic arterial signal.
Now, contrast that with outflow issues. If you have venous congestion, the flap gets incredibly tense and swollen. It turns a dark purple or blue color. Capillary refill is actually brisk, almost hyperactive, and you lose that classic continuous monophasic venous windstorm sound on the Doppler.
Time is tissue. Waiting for a flap to turn purple means you are already behind the 8 ball. That is why continuous objective monitoring is taking over the postoperative wards. We are now using near-infrared, or NIR, spectroscopy.
You place a small surface probe directly on the skin paddle of the flap. It uses near-infrared light to continuously measure hemoglobin oxygen saturation. It reads up to 2 centimeters deep into the tissue, giving you data far below the superficial capillary beds.
The saturation level usually stays relatively constant, averaging around 83%.
Yeah.
If there is a sudden drop in venous or arterial flow, the electrical tracing on the monitor changes immediately.
This happens hours before you ever see the flap turn pale or purple. It triggers an alarm and buys you the critical time needed to rush the patient back to the OR, open the chest, and revise the clotted anastomosis before irreversible damage sets in. That technology absolutely saves flaps.
Let's pull all of this together and look at the outcomes and the real-world trade-offs. Flap selection is a balancing act. You have to constantly weigh the morbidity rates of the donor site against the survival rates of the flap itself.
Let's lay out the final clinical realities regarding abdominal wall strength. If you perform a bilateral free TRAM, sacrificing significant muscle on both sides, you are looking at a post-operative bulge rate of up to 21%. That is a massive hit to the patient's core function.
Now, if you do a bilateral DIEP flap, preserving the rectus muscle entirely, that bulge rate drops dramatically to around 4.5%. The patient's ability to perform a standard sit-up stays at 95% of their preoperative baseline with a DIEP.
Now look at the SI flap. Because you do not violate the abdominal fascia at all, the true hernia and bulge rate is an absolute 0%. Patients get out of bed faster, and they require significantly less narcotic pain medication.
A 0% hernia rate sounds like the holy grail of reconstructive surgery, but you pay a massive price for that 0%.
The SIA flap has significantly higher flap loss and thrombotic complications compared to the muscle-sparing free TRAM or the standard DEP. The superficial vessels are just smaller, more fragile, and the cutaneous perfusion territory is limited.
You end up with a much higher rate of redo arterial and venous anastomosis simply because of the severe size mismatch between the tiny SIA pedicle and the large internal mammary vessels.
In real life, that mismatch is the enemy of success. That leads to the ultimate surgical pearl for autologous reconstruction. The key to successful microvascular surgery is making it as macrovascular as possible.
You want large caliber vessels with high flow rates. You want an optimal size match between your donor pedicle and your recipient vessels.
Do not force a bad perforator just to save a tiny strip of rectus muscle. If the DIEP perforator is under 1.5 millimeters, or if the SEA pedicle looks completely inadequate, take the muscle. Convert to an MS2 free TRAM without hesitation.
Prioritize the robust blood supply over the anatomical ideal because a beautiful muscle-sparing dissection means absolutely nothing if the flap fails and has to be debrided on postoperative day 2.
That is exactly the practical reality check we need to keep in mind.
Looking at everything we unpacked today, from respecting the volume algorithm and mapping with MRA to knowing your heart ischemia thresholds, the overarching theme is clear. You cannot force the anatomy. We established that the abdomen remains the gold standard donor site, but only when guided by strict patient selection. We discussed how CTA imaging maps the DIE branching to protect the intercostal nerves, while MRA provides the contrast resolution needed for spotting tiny perforators. We reviewed why the internal mammary artery, with its 25 milliliter per minute flow rate, heavily dominates the thoracodorsal system. We walked through the critical intraoperative maneuvers, dissecting the DIPP pedicle to a safe 3 millimeters, using the Zen technique to prevent pedicle kinking in a SIEA flap, and seeking lateral perforators for the SGAP to ensure adequate pedicle length. And finally, we covered the strict ischemia windows and how continuous NISI or spectroscopy identifies venous or arterial failure hours before clinical signs appear. Flap selection is not just about preserving muscle, it is about matching patient anatomy, vessel caliber, and real-world flow dynamics.
The level of precision required in the OR today is staggering, but it really makes you wonder where we go next. If CTA and MRA have already revolutionized our preoperative planning, think about the integration of real-time augmented reality mapping directly in the OR. Imagine putting on a surgical headset and seeing the preoperative MRA data overlaid flawlessly onto the patient's skin. You could illuminate the exact location, the precise depth, and the exact caliber of every single perforator before you even pick up a scalpel. How quickly will that kind of technology render the tedious, exploratory perforator dissection entirely obsolete?